afternoon, everybody, and welcome to this Association of British Paediatric Nurses Association webinar. And we're pleased to introduce Claus Jensen for this afternoon's webinar, who will lead you through a webinar focusing on enhancing paediatric nursing, focusing on critical signs. So good afternoon. My name is Simon Hardcastle-Wall. I'm one of the finance officer for the association. And it's great to see so many of you dialing in and on the call. And there'll be other members of the ABPN in the webinar who will keep an eye on the chat and for Claus. And if there's any questions, I'm sure Claus will let us know what you prefer to do, whether that's throughout or whether at the end. But I'll duly hand over to Claus, and I hope you enjoy this session. Slides will be shared on the ABPN website, and we're still sorting out all of the recordings to be uploaded as well. However, without further ado, I'll hand over to Claus.
Yeah, okay. Thank you for the invitation. It's an honor to be here to talk to you today about one of my research areas. So I am an associate professor in children's nursing and a clinical nurse specialist at the Aarhus University Hospital in Denmark. And you are free to ask questions during my presentations, and hopefully then someone can give me a heads up with when there's many questions, and we can stop. Otherwise, I have timed my presentation, so there will be room for question in the end as well, and discussion about our different findings. So great, now it won't change slides.
Simon? Claus is having a problem.
It won't change my slide, but I think I just will try to stop sharing and then share again to see.
Yeah, perfect. Thank you, Claus.
Yeah, now it's working. So I'm just to show where I'm situated. I'm in Aarhus. That's the blue dot in the map.
Sorry, Claus, we can't see the present. I can't see the presentation now.
Oh,
unfortunately.
Oh. It's going good. I'll try again.
It must be the time difference.
Yeah, exactly.
Oh, we can see it now.
Yeah, and then I'll go in presentation mode.
Yeah.
Yeah.
That's it.
Fantastic. Thank you, Claus.
Try again then. The blue dot, that's Aarhus, that's the city I'm in now, where I'm working, and you can see some different pictures of the hospital, Aarhus University Hospital. And there's a red circle around the pediatric department, which is part of a larger hospital. We're the second largest hospital in Denmark, and the second largest pediatric department. So my main research areas, you can see here, it's around child and family-centered care, where we primarily, in my research group, focus on restraint-free clinical practice. Then we also do a lot of research in children and young people in pain. We have developed some virtual reality games for children going through needle procedures. And we also worked on some features about augmented reality. If you look at the pictures on the screen, you can see a girl in a yellow shirt with an iPad in front of her. She's playing a game, but not touching the iPad, so she can have her arms free while doing some kind of procedure. And my main area of research, which I'm going to talk to you today about, is clinical deterioration, pediatric trigger tools, and which signs and symptoms does children have that are not measurable, showing signs of clinical deterioration. So, well, first of all, we have and use, I think, in most pediatric departments worldwide, trigger tools like pediatric early warning scores. They are used daily, many times a day, in order to assess and identify pediatric patient in risk of clinical deterioration. Most of the early warning scores that we use are primarily based on vital parameters such as heart rate or respiratory frequency. And there's a great variety of early warning scores used worldwide. Many are developed at local hospitals and only validated in single center studies. So there is a lot of gap within the research on early warning score systems. We also know that the way they work, that you get points for abnormal vital parameters and you get an aggregated score, does not fully complete the full picture of the chain of clinical deterioration in pediatric patients. So that's why we did some research on early warning score systems, which are the what are the barriers, where does it not function well, and we also noticed that they also fail to recognize all children in risk of clinical deterioration. So children with having a clinical deterioration seems to be a problem that goes on even though we have clinical assessment tools. So for the next slide, I would like to illustrate some of the challenges with pediatric track and trigger tools. So because we use it daily, and even though we use it daily, there might be some issues. So if the technique will now, I will show you a movie of a child with some kind of respiratory distress. So your task would be to have an idea of the respiratory frequency, have an idea about how to describe the respiratory sounds and the respiratory work, and could be able to classify that after the end of the movie. So hopefully it will work. So now I will even challenge the technique even more. So I will stop sharing, and I will share another screen. So hopefully you will see a Mentimeter website now, and then I would like on your smartphones or other electronic devices to go to menti.com. You can see the website on the screen, and then you should use the code that was also on the screen, and then just tick on the respiratory frequency you counted on the movie. And if you did not count 40, 42, or 46, just tick the number that is closest to the respiratory frequency that you just counted.
Claus, I can't see the screen that you mentioned. No.
Sorry. I will.
The challenges of technology.
Yeah. Maybe I was too optimistic.
Yeah.
Yep. So
something is there now.
yes, so go to menti, MENT.com, and then enter the code you see on the screen. Yep, I can see somebody has already entered. Just get 1 minute more, then we can see if we agree on the respiratory frequency for this child. So we can see that most of us counted around 42 and some counted 46 and a few too counted 40. So this was just an example that I know it's a movie, but if we do this in real-time, research show that a quite simple measure, respiratory frequency, is actually difficult. It's even more difficult in small children. So doing these bedside observations is quite complex and requires a professional knowledge about pediatric patients. So if you go to the next question, then you are to tick which kind of respiratory effort you observed, and you can enter more than one respiratory effort here. So just go ahead. And you're already on the way, I can see. So the next observation, bedside observation you did here on the movie, it also showed that, well, all of us seeing the movie did not observe the same. We saw, most saw intercostal retractions, only one saw nasal flaring, and 2 saw abdominal breathing. So our observation that we did on this child, we do not agree on the basic nursing observations. So once again, it just highlights that it's difficult, it's complex, and it's unfortunately in clinical practice today, this is one task that is done many times a day, and it's not has not that much value doing these bedside observations.
Klaus, just to advise, a number of people have said that they could only submit one answer.
Oh, sorry. Okay, but then the last one here, you only have to submit one answer. So how do you assess this child respiratory work? Mildly, moderate, severely increased, or normal? Yeah, so the final question here. So we did not agree, the 23 persons who had submitted an answer here, if this was mildly, moderate, or severely increased respiratory work. And I know that this is a movie and it's not a real life setting, but we've done research in real life setting where 2 nurses would do the same observations bedside on the same patient without talking together. And we do find that it is difficult to make these bedside observations and registrations, which just highlights the importance of teaching about this and doing more research. So this movie, and this was just to illustrate how complex bedside observations of pediatric patient is. And this was just a minor part of the observations that we do every day. So now I will leave this and go back to my presentation, I hope. Yep. Do we see the presentation now?
Yeah.
Yeah, great. Yes. So I will talk some more about clinical deterioration in pediatric patients. So most of the pediatric patients that are hospitalized they're hospitalized with different conditions, and they have the potential to deteriorate and become life-threatening if we do not attend them timely, or if we not react correctly. So early identification of bedside observations and doing bedside observations are important. And we are, as nurses, around the patient 24/7. So seeing doing the observations and know how to respond and react is quite important, and we play, as nurses, an important role. And we know that changes in vital parameters that indicate decline in a child's status may be present up to 24 hours prior to an adverse event. So we have a long time for many patients to respond and to recognize and to make some kind of intervention, so that we will, so the child will not have a critical event.
Klaus, someone has asked if you have descriptors to assist decision making.
Can you ask that again, Fiona?
Someone's asked if you have descriptors to assist decision making. I think it's probably in relation to some of the different categories that you had previously, like, moderate, severe, etc.
Yeah, as part of the pediatric early warning system or scores used, there are some action cards to support what to look for, but they do not give hints to how do you look when you are mild, moderate, or severe. They only give information about you have to look for retraction, you have to look for abdominal breathing, you have to check for respiratory sounds, and then in our setting in Central Denmark region, we did a lot of teaching years ago in order to have the same understanding how you look when you're 6 weeks or 6 months old with respiratory distress. So the pediatric nurses see a lot of different movies, so we get the same understanding. Yeah, but what we also know about these early warning score systems is that we do not always follow them. There are some mandatory time schedules for when to reassess the child. The nurses do not always follow these because they do not make meaning for them. So they use their clinical judgment and say, I don't have to do this bedside observation every 6 hours. I can do it every 8 hours or so on, because they do not find that the system of early warning score, track and trigger tools fits all pediatric patients. And that has that can have some not so good outcomes for the patients if we do that. Yeah, so we can see here, that's just an example from a review that up to 60% of the clinical duration events were due to we did not escalate care and respond in time to signs that were documented in the patient charts. So perhaps the perfect early warning score system has not yet been developed. They are mostly based on vital parameters. And using this system, there's a risk of overlooking children without a normal stress response, or children with impaired physiology resulting from a chronic disease. And the early warning scores they are now do not distinguish between different and individual patient response to illness. So in our experience, children with expected normal vital signs frequently undergo unnecessary clinical assessment, and that leads to an increased workload for the pediatric nurses. It leads to a kind of a alarm fatigue, and that has been documented in our own research and in other research for reasons for not complying with the bedside observations or with the protocol for escalating care. So that was one of the reasons why we were looking into this. What is there more than these early signs that are primarily based on vital parameters? Are there other signs that nurses use when they are bedside doing their observations? Because we know that nurses play an important role. We are the one, as I said earlier, with most frequent contact with the hospital children and their families. Researchers also indicated that nurses' clinical or personal judgment of a child and adolescence also is an important in the chain of things that happens prior to a critical event. But these subjective considerations, they are rarely included in standard assessment tools as a early warning score system. So perhaps we need to look beyond pediatric trigger tools that only focus on vital parameters, so that we can make it more meaningful for nurses, so that they would do more bedside observations that are not only based on things that we can measure, but also based upon things that we observe and that we can sense and feel, being close to the patients. But starting our recent research, it was unclear which signs and symptoms that would trigger the concern for nurses caring for pediatric patients. So we had to find a way to clarify these signs, and could that help nurses put their intuition into words, and so that we could take action on clinical deterioration at an even earlier point, even before the vital parameters changed. We have seen that in some adult publications for adult patients, but not within pediatric patients.
Someone's said,
Yep.
Claus, is it pattern of recognition rather than intuition? And whether you have a parental concern trigger as well, which can be useful.
Yeah, that's an interesting, and it could be a long discussion about this pattern of recognition. That's part of it, and actually I will illustrate that with the next slide. That's also part of it. That some of the nurses' intuition or clinical judgments is based on things they have seen or experienced before, but it's more than that, and I will get back to that later on in this presentation. Parental concern is also important, and we'll also address that later on in the presentation, because some of the research that we've done and others done, that's parental concern is important, but it's also some nurses also experience that the parents can be a barrier for doing bedside observations. But I will get back to both of those issues. So for the next slide, there will be a picture. Actually, there will be two pictures. They are almost identical. One of the pictures has been manipulated a little bit. So the task for you that are here today will be to raise my hand on the screen when you can see the difference between the two pictures. So two pictures. I've manipulated with one of them. They are changing rapidly. So you just raise your hand when you can see what is wrong with one of the pictures. And if you get sick at looking at the screens, so just close your eyes so you won't get bad. Wow, that's quick. Some of you may seen it before then, because I've borrowed it with permission from Damien. For those of you who have not seen it, I can help you a little bit. The things that you should look for is not related to the soldiers. There's something missing in one of the pictures, and it's related to the airplane. So in one of the pictures, the airplane's motor is missing just under the wing. It's missing in one of the pictures. I will go away from the slides now. So this was actually to illustrate something about the pattern of recognition. So if I were to talk to you next week and show you the same slide, I would anticipate that you would raise your hand quite quickly because you now know what you were to look for. And it's the same about the children. So if you know which signs and symptoms, other than vital parameters, that we should look for, then we will identify it early, and we will be able to respond at an earlier time point. So that's why we were so occupied with getting information about what are those signs and symptoms. Could we have nurses articulate their intuition, put it into words so that it could be incorporated in clinical practice? So I'll just look at the time. I will dare one more time to go to Menti so I can activate you all for just a few minutes. Maybe. And just let me know if you see the Mentimeter screen as well.
I can see a word cloud.
You can see a word cloud?
Ah, there we are. What's
Yep.
up? Which signs and symptoms?
Yes.
Yeah.
So we'll just add in the new code and then type in signs and symptoms that come into mind to you, that are signs and symptoms of clinical deterioration in a pediatric patient. Yeah, so a child being quiet, I can see that the bigger the letters are, the more people have written it. So quiet, parental concern are some of the words that many of you have written. I can see that many of the words you have written here I will come back to many of them, as this was also some of the signs and symptoms that we identified during the different kind of studies that we've done in this area. So we kind of align quite good with the nursing indicators that I will eventually talk about, that we have analyzed and that we have published as other than vital parameters. We have some nursing indicators of clinical deterioration. So we are very much aligned, I can see from your answer. So thank you for participating here, and I will try to get back to my presentation. So are you seeing the presentation also? I hope so. Otherwise, you just let me know.
Yes,
So,
we can see.
Yeah.
Perfect. So for next slide, I will present some of the research that we did, and they will be based on our own research and research done by other people. So for our research group, we were occupied, as I said, with this. I think you all have been there in a patient room with a patient with normal vital parameters, but there's something that's not quite right with the patient. You get concerned somehow. You want to maybe do some extra tests. You want to have your colleague come and look, and you will call for the pediatricians to have a look. But the vital parameters, they look quite stable and normal. So some kind of instinct says that to you that there's something wrong here. So we want to look at that from a research perspective. And the first we did was we did a scoping review. So we went through the literature to see what was published within this area that could enlighten us. Then we did a qualitative single center study at our own setting. And the last study we did was a focus group study in both Denmark and Norway. So from the scoping review, we did a very broad search. So we had over 5,000 citations that we went through, screening, title abstract for did it say anything about what we were looking for, and we ended up only including 7 studies. They were all qualitative studies, so it was observational studies or focus group or interview studies, and none of them had the primary aim of looking at signs and symptoms. But we could see in the data presentation that there were information about signs and symptoms of clinical deterioration. After that, we did a smaller study at our own hospital. One of my PhD students did some precipitation observation with experienced nurses and did some focus group after that. And she was also, the primary aim there was what are the signs and symptoms, what are the nurses' observational practice in order to identify children in risk of clinical deterioration. So following that, then we did this multi-center study where we used focus group as method. We did it in pediatric departments in Denmark. And then we also did it at a university in Norway, and a university providing special education for pediatric nurses in Norway. And what did we then find? Well, overall, we found 3 themes that were related to the signs and symptoms that would trigger nurses' concern beside vital parameters. So one of the themes were titled Nurses' Way of Gaining Knowledge about Children and Adolescents' Clinical Status. Another theme was challenges nurses faced when assessing and observing children and adolescents in clinical conditions. And the final theme was around what are the specific signs and symptoms that would trigger nurses' awareness. And we'll now go further into these aspects. So let us begin with the first theme about how nurses gather information about a child's clinical condition. Nurses emphasize several key components that would shape their understanding and decision-making process. First and foremost, their intuition, or gut feeling as they called it, were not based on guesswork, but arises from accumulated clinical experience. Over time and by repeatedly observation children in various healthcare situations, the nurses highlighted that they kind of developed a sense of something being wrong or not quite right with the patient, and even though the vital parameters were normal or within a normal limit. Secondly, the nurses rely heavily on their senses, their ability to physical and visual assess a child. They described how they might touch the child to feel the temperature or tone of the skin, or observe facial expressions, the change of color, the muscle tonus, and listen carefully to the child's breathing patterns. And the tone of the child's voices were also important clue to get information about the child's clinical status. And all these sensory cues provided an immediate and real-time feedback that are not part of the standardized early warning score system used in Denmark anyway. Another crucial source of information were parents, as one of you asked questions about the parental concern. They talked about how the parents have knowledge about their child's usual behavior, the child's mood and routines. And nurses emphasizes the actual engagements with parents to gather insights about any subtle deviations in the child's normal state. Parents' observation often acts as an early warning for the nurses, and making the nurses more alert, even though there were no measurable changes. Experiences, or the nurses' experience, also played a fundamental role. As experienced nurses, they had the ability to integrate all their experience, their sensory inputs, and the parental insights, and their own clinical knowledge, and were able to combine these to make sense of the situation in the patient's room. And they also talked about how the less experienced nurses, they were also, some less experienced nurses were also part of the focus group study, how they could overlook signs and symptoms and would ask the experienced nurses to join them in the room, so they could be mentoring and kind of get a validation of their assessment. In that way, the experienced nurse would help the inexperienced pediatric nurse to have some kind of intuitive and build intuitive capacity over time. So this themes also kind of illustrated the complex and multi-layered approach that nurses or pediatric nurses use to gain information about the patients, and how they interact with the child, and how they comprehend all these different information that are gained through using different kind of senses. The nurses also highlighted that they were challenging when observing and assessing children's clinical condition. They all talked about how it would be difficult to do it during the night or during the evening. The nurses talked about how the reduced lighting in the patient room would sometimes be challenging, and that the child's sleep behavior or changing in the child's sleep behavior also would complicate their ability to do observation, and complicate the ability to sense these subtle signs of clinical deterioration. Then also talked about when the children were tired or drowsy or withdrawn, that would make it challenging to distinguish between normal sleep pattern and signs of clinical deterioration. They also talked about the parents, and the parents that would like their child to have a normal sleep during night, so they would interact with parents and have discussions or talking about how it is important to assess a child and do bedside observation also during nighttime. So in that kind of way, the parents could also be a barrier for doing the observations in a timely manner during evening and nighttime. Then they talked about the children's physiology ability to compensate, as many of you know, that unlike adults, children have remarkable ability to maintain normal vital signs even when their condition is worsening. So this was also influenced the bedside observations that were non-measurable. So they were also able to mask some of the early warning signs that would then challenge the nurses. And it was mostly the inexperienced nurses that were the most challenged by this. And then parental behavior, as I talked about, was also a challenge. The parents could give valuable information about the child's medical history and the child's normal response to illness or to interacting with other people. But they also talked about how the parents unintentionally maybe overstate or understate the child's symptoms. So that would also be part of the processing of the information for the nurses that would make it difficult or maybe challenge them doing this observation. And then something that we did not think about beforehand, then lot of the nurses talked about the presence of electronic devices like smartphones or tablets was mentioned as a barrier. They could be used in a positive way in other things, that they could be used as a distraction for children that go into procedures or having a blood pressure measurement. Then they could use the smartphone as abstraction. But it also were a barrier to get and able to interact and establish a rapport with the child if the child were mostly focused on looking at their phone and not interacting with the other healthcare professional or the other adults at the bedside room. So these were the most of the challenges that the nurses were observed and that we could find described in the international literature. So this also illustrates the complexity of doing these observations, and first of all getting access to the child, and then how to interpret the different signs and the interaction with the child's parents. The nurses also talked about quite specific signs and symptoms that would trigger their awareness. And this is the third and final theme. So the first key observation nurses rely on was related to the respiratory frequency and the respiratory work. The nurses noticed that early warning signs such as use of accessory muscles and breathing sounds and changes in the respiratory pattern was something that they would look for. And they would look for this, and they will notice changes even before that they could measure it in oxygen saturation, for example. They also paid close attention to indicators related to circulation. So this included monitoring the child's skin tone and the skin texture, looking for paleness or mottling, as some of you also entered at the word cloud. If the child was puffy around the eyes. And then they talk about how the child's color gets a different hue and expression when the child condition worsened. So it was not just a question about whether the child becomes pale or cyanotic, but they also talked about the skin texture. The elasticity of the skin were also highlighted as important unmeasurable signs. So the nurses here also talked about how to access these signs and symptoms. They could not do it without having small babies in their hands, or taking their hands to the chin or the arm of an older child. So this were important way to get this kind of information about skin texture, for example. So another crucial observation that the nurses talked about was the child's level of conscientiousness. The nurses described this as very important, being sensitive to eye contact, to how the child would interact with their parents or the healthcare professional being at the bedside room. And they also talked about how the child movement pattern would change, or they would observe how would the child move around in the bed. So even small subtle signs could be decisive for the nurses to be aware of any changes in the child's clinical condition. Yeah. They also talked about the facial expression of the children, such as worry lines, or if the child would look anxious or panic in their eyes. And they then also talked about the parental concern here. So this was also an important aspect. And finally, they talked about their own judgment or clinical intuition. They referred to it as their gut feeling. It was an essential part of being at the bedroom and looking for the specific signs. It was accumulated during their experience as pediatric nurses. So they talked about how they could sense that something was not right with the patient. So this was one of the most significant indicators that the nurses reported. And the term described this instinctual sense that something is not wrong with the child, even when the vital parameters are normal. The nurses often experience this feeling when they observe different or small subtle changes in a child's behavior. And this intuitive awareness was critical for them. And it was described in various terms, as you can see here. And the one nurse talks about, like, it's a feeling that something's not quite right with the patient. Another nurse talks about, the more experience I gain, the more I use my gut and use my gut feeling frequently in conjunction with the vital signs. So here they talk about how they combine this intuitive feeling that something is wrong. They talk about how the unmeasurable signs are used combined with vital parameters and combined with the early warning score. So this gut feeling or intuitive feeling was described as both reactions to subtle signs from the children or young people, but also as a feeling based on the nurse's own intuition gained through experience. So together, these different signs and symptoms formed a kind of integrated approach that would enhance the nurse's ability to recognize children in risk of clinical deterioration. Then we tried to look at our own research and the research that we could find in the literature, and then kind of condense it to nursing indicators of clinical deterioration. So we came up with these 6 indicators: change in respiration, change in circulation, level of conscientiousness, facial expressions, parental concern, and nurses' clinical judgment. So if you take a closer look at the nursing indicators, then as I talked about before, it is change in respiration. Nurses talk about how they experienced this before vital parameters would change, and it was primarily around the use of accessory muscles or the kind of sounds that the child would make, or if the sounds would change in when they get worse with their respiratory problems. The second indicator was about change in circulation, and this was then about the skin color, checking for pallor, mottling, or grayish tone in the child. And this was then about being physical with the child so they could get an idea of the skin texture. And the level of conscientiousness was also very important for the nurses, so that's why we included this as an indicator of clinical deterioration, and including change in eye contact and how the child would respond to stimuli or interaction with parents or healthcare professionals. So and then there's facial expression, which was predominantly described in relation to younger children. The younger children, the nurses would talk about how they could enter a room and the child would just lay still in the bed, just looking worried, and that would be a red flag for nurses. And parental concern, as we also talked about, an important indicator of that something is wrong with the child. And nurses emphasizes that parents' observation and how they express concern gave them further insight into the chain of the escalation chain towards clinical deterioration. And the final one was the nurse's clinical judgment. So that was the aim of when we initially started. Could we get the nurses to talk more about this gut feeling and what would highlight this gut feeling? And we did get some more information. Some of them are part of these nursing indicators, but still there is, maybe it's recognition or pattern of recognition, that there are some things that the nurses cannot articulate, but it's a gut feeling that something is wrong. So that's why this is also part of the nursing indicators. It was also would also in the future maybe give a stronger point of argumentation with the pediatricians for escalation care if we can use our clinical gut feeling and then relate it to some scientific work. That's our hope that these nursing indicators could inform clinical practice and give of us as nurses a stronger platform to articulate and to argument for the child's clinical status. So in conclusion, well, the research that we've done and I talked about today, combined with other researchers, underscore the importance of that we use both the objective assessments and we do use the more non-measurable observations as well. And hopefully we can combine these into some sort of unified early warning score or some kind of uniform observation support tool, so that maybe predominantly the nurses that are new in pediatric nursing, they will get help to what to look for, what are the red flags that are the non-measurable signs, and so back to the with the slide with the picture changing all the time, so they know what to look for and can respond and react in a timely manner. So that was the last slide. So now we have some time for questions or comments or discussion. Yeah, so please.
If anybody wants to raise their hand, and then we'll come to you. While that's happening, I wonder whether Jean and Anne-Marie in particular want to articulate some of what they put in the chat. Anne-Marie, particularly in relation to Martha's rule, and whether there's anything like that in Denmark. So over to you, Anne-Marie.
Hello, can you hear me okay?
You're on mute.
Hear me? Is it connection?
I
can hear you now.
Yeah.
You can hear me. That's
yes.
Good.
Yeah.
Yes. I've been very interested in the work that you've been doing and seeing the similarities between your findings and the work the NHS England Royal College of Paediatrics here in England have been doing in developing work from other pews, and the new system that we've called, it's called SPOT, linked to pews. Two things in that are quite new to us is the ability for parents or carers to trigger concern. So that's part of the documentation, that it can be used in conjunction with a raised pews score, but the parental concern on its own is something that can trigger need for medical review. And that's come through a case here a few years ago now, a 13-year-old that died, whose parents were very articulate, insightful people. If you look at her history, really she shouldn't have died. And we've now got this rule, which is law in England, that parents can ask for a review of their child when they're concerned, and that's been built into our new Pews score. And similarly, well, I don't know if you've got anything like that, Claus, in Denmark, so it's sort of a legal ruling, but also the other aspect that has been given more recognition is exactly what you've been talking about in terms of nurses or healthcare professionals' clinical intuition, and likewise your gut instinct again can trigger a need for review, that it doesn't have to have a scoring of a high level on your Pews score. I put a link in the chat to the work from the Royal College of Paediatrics. We're still in the process of reviewing the charts. I don't know how many people who are on the call actually use them in practice. My background has been in academia recently. Yeah, so stop talking, thoughts.
Thank you, Anne-Marie. I know about Martha's Rule, and I've heard I read about it and heard some presentations, and we do not have that in Denmark. So not in a legal way and not in a clinical way. So as it is now, a parental concern would not automatically be a red flag, and then the emergency team would be at the room a few minutes later. There are people talking about it, and we also talk about it with our colleagues in Norway, because they had a similar case as the one you're describing now. So they are also working on including parental concern in their Norwegian early warning score system for pediatric patients. And we are as well looking at that at our local hospital, how to incorporate it. We've been talking about it because it can be challenging. So should we give parental concern points as we give the vital parameters, or should it just be parental concern and then the some kind of MAT team or emergency rescue team will come to the pediatric department? So we're talking about how to incorporate it in clinical practice in a way that would be applicable.
I think just to
Jean,
add that when you were saying about, sorry, I was just going to add.
It's all right,
that
carry on.
In terms of response, that within the whole of the PEWS chart, that it wouldn't necessarily be an instantaneous medical review. Okay. That each element is scored, much like you were doing with your Mentimeter low, medium, high, or emergency response. So there are words that give a clue as to which of those is going to be triggered. But thanks, Claus, and help.
Jean, is there anything you might like to say?
Thank you, Fiona.
So we've got hands up. So we've got hands up first. I think Helen was first.
Oh, okay then.
Sorry.
I can't see any hands up.
Okay,
it was Anne-Marie's hand went up. And Helen, your hand has been up for a little while, so not too sure if you've got a question too. I think they were what they call legacy hands, Simon.
Okay, yes,
I think so. Yeah. Honestly, this conversation could just go on quite a while, and not going back over what has just been said, but adding into supportive elements, which is professional judgment, situational awareness of the rest of the children who are being cared for in any clinical setting, looking at acuity measures and the number of staff that are available to do the caring, do the monitoring, and take the observations. Without that combined approach, there is more risk of these clinical features not being spotted. So I just want to leave it there. We are teaching students around all the things that we've been discussing today. Very, very important. So thank you. Those are my observations.
I totally agree. We have to see it as a complete system with a lot of different elements, and not just a score or not just bedside observations, but it's an integrated part of many aspects. And it's a whole system that has to work if we have to do it better.
Thank you.
Claus, can I just ask, are you linked? Have you linked together with Damien Rowland from the University Hospital of Leicester, who's been leading nationally around PEWS and
the Puma study? I've talked to him several times at different conferences worldwide. So
perfect. Okay, there's no other hands up, so it's 5 o'clock. So thank you very much, Claus. It's great to see the work that you've been doing in Denmark, especially in Aarhus, which is where when I qualified, I nearly moved to. So I visited Aarhus a lot. So it's great to see. And there was not really a lot then for paediatrics. So obviously that was my speciality. So it's so great to see that in scabies that there's lots of work around paediatrics taking place. So okay, we'll follow up on anything else that's in the chat, and we'll make sure the slides, Claus, are put onto our ABPM website, and once the recordings are sorted, we'll make sure they're all shared as well.